Hi everyone, welcome to DPT 829 PI2. This is lecture number 1, kind of an overview of some of the foundational materials that I want just to point out to you that we'll be using or certainly referencing all through the course. And they really come from the Guide to PT Practice. So as you can see there, I have the link to the Guide to PT Practice, which is located in the APTA website. Just know that if you click that link, you will still have to log in to the APTA website using your credentials that you set up um, in the past in order to access all of the material. For many years, the guide was actually a written book document, and several years ago, the APTA decided to post it solely online so they can keep it updated and relevant for all current professionals. So just kind of the Guide to PT Practice is informs our practice, and it really, I would like you to review just chapter 1, the introduction, which kind of puts the foundation of our practice based on 4 major constructs. So it talks about the International Classification of Functioning, Disability, and Health Models, as well as the biopsychosocial model. It talks about evidence-based practice, a bit about professional values, and talks about quality assessment. Again, all those constructs as kind of foundational to our practice and our profession. So kind of at the baseline, the guide is informed by a number of disablement models. So disablement models are models that are used to help describe and to delineate all of the interrelationships that occur with and among disease processes or injuries or health conditions that occur when you're working with patients. These are the kind of the 3 foundational disablement models, and you've probably seen them before. The top Nagy model was kind of the original, really kind of the easiest to understand, and the Nagy model talks about disease and pathology in terms of impairments, functional limitations, and disabilities. So if you'll see there on the left, in the Nagy scheme, a person may have an active pathology, say a hip fracture. And within that active pathology, there are usually impairments, which are the anatomical and the physiological and the mental and the emotional abnormalities or losses that occur because of that diagnosis. So the impairments of a hip fracture may be loss of strength, loss of range of motion, pain, things like that. Then those impairments affect a person's functional limitation. So the performance at the level of the whole person. So functional limitations may be things like impaired ability to transfer or unable to ambulate, unable to feed yourself, things like that. And those functional limitations have an impact and integrate with a person's disability. So their limitation in performance of society-defined roles. So their inability to work, their inability to go to school, their inability to be a part of the community in whatever role that they are involved in. So you can see there's that kind of interrelationships between the pathology and all of the sequelae that occur, and they define it very specifically in the Nagy model. There's also the World Health Organization classification of impairments, disabilities, and handicaps that's described similarly to that Nagy model, where they talk about the disease, the impairment, the disability, and the handicap. There's also a model from the National Center for Medical Rehabilitation and Research classifications. This is one of the more recent models from 1992. Again, and their terminology includes pathophysiology, impairments, functional limitations, disability, and then the added factor in that model is the societal limitation. So the restrictions and the attributes to social policy or barriers that limit your fulfillment of roles. So there's several different ways to describe the interrelationship of health impairments that occur, and these are just kind of the foundational method to be aware of. I certainly think knowing the terminology of impairments, functional limitations, and disabilities is important because it will help set you up again for further discussion, and then another model that we'll talk about in just a minute. So the World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of infirmity or the absence of disease. So within that, this biopsychosocial model is kind of the theoretical construct that kind of elaborates this definition. So according to this model, a person's health status is determined by the interplay of all of these factors that you see here. So the person's status based on biology and the biological status, the psychological status, and the social status that all affects and interplay in terms of a person's status. So, for example, two people with the same pathology may have different levels of motivation or different levels of socioeconomic resources that might have caused very different outcomes in the biological processes that are impaired and affect may cause a person to be impacted very much differently, again, by the same concern or the same health issue. So I think you can see about how all of this is interrelated, and certainly you talk a whole lot in this program about all of the biological and even the psychological effects that occur when a person's health is impaired or involved. And then, the PI class, especially this semester, will talk much more in depth about some of those psychological and certain those social or socioeconomic factors that interplay on a person's health and how to be aware of them and to work within that model to help the person the best we can. So this is the ICF model. So in 2008, I believe it was, the American Physical Therapy Association decided, along with the World Health Organization, to adopt this ICF model, the International Classification of Functional Disability and Health. This model of functional disability, and they've decided to, instead of using all of the other models that I talked about prior, this is the model now that APTA and WHO are using to hopefully provide a unified standard language and framework that enables for the collection of data and for practice and for research all around the world. So as you saw in the past, there were kind of different ways to describe different aspects of health. Now we're supposed to use this kind of one model so everybody's talking in the same terms. So if somebody's doing research in this country and in another country, the definitions are the same, so that and the practice will be the same to describe how people function in their daily lives. And again, this includes that not only the biological factors, but also the psychological and the social factors that to describe how people function in their daily lives rather than focusing exclusively on their medical or their disease-specific diagnosis. So again, this is supposed to be a universal model of health and functioning and disability. So you can see there's two parts. The ICF model on the left has part 1, which is a description of the components of the functioning and disability that are associated with that health condition. So the functioning and the disability include body function and structures and activities and participation. So the body functioning and structures are kind of like your impairments. So if you go down on that model, it talks about the changes in body function, the changes in body structure. So again, that might be your loss of strength, your loss of range of motion, your pain, and those changes directly on the body functions and structures. And then it also includes in that first part the activities and participation. So the changes that occur that a person has to carry out or work in their daily life. So that might be, again, their activities, their transfers, their ambulation, their mobility, their speech, and then their participation in their patient-specific life activities in terms of their social function and their daily activities. So that's part one on the left there, kind of the biological pieces and how the impairments and the function limitations and the participation are described. And then to the right are the contextual factors. So these are the external and internal factors that affect how a disability is experienced by the individual. So environmental factors that may influence a patient's experience or disability may be things like their environment. Do they live in a second floor home or they live in a one floor home? Their social social attitudes, the legal and the social structures that the person lives with or in, climate factors, things like that. And then personal factors that affect how a person is experiences their disability or their functioning include things like their age, their coping styles, their social background, their education, their own personal behaviors and patterns and things like that. So you can see the contextual factors are all the things that define and help describe how a person experiences their disability. Within environmental factors, some of those factors may be barriers to a person's participation and a person's experience with their disability, and some may help that. Some people may have more motivation than others. A barrier may be a person that lives on the second floor, has second floor walk up, and not a first floor accessible home setting. So the ICF, this is just another method or model that depicts the ICF model, and this looks at and recognizes all of the components as interactive constructs, and it really kind of looks at all of the complexity and the interactions that occur between the body functions and structures and the activities that the person needs to be able to perform, and the participation that the person has within, again, their social roles or their own defined work roles. And then that bottom piece are the personal and environmental factors that can be barriers or facilitators to the person's ability to participate, and that again may affect the person's health, cognition. So changes that occur in one area usually affect others. They may not affect others, but you can see how they're just very interrelated. So another part of the Guide to PT Practice talks about the components of evidence-based practice. And certainly the physical therapist practice incorporates all components of EBP. So when you talk about all the components, it's using and integrating the best available research evidence along with the practitioner or the professional's clinical expertise and the circumstances that the patient is in to make decisions regarding what the best method of practice and management that you carry out. So it's combining. EBP is really a triad of information, that best available practice, the clinical expertise, and then using or incorporating the patient's or the client's values and circumstances to help make the best decision. So you really need to think about and include the patient's circumstances and ensure that the patient or the client understands all of the options for care, all the benefits, the risks, the costs, and it's based on that therapeutic relationships where the therapist works collaboratively with the patient to make decisions for their care. So another area of the guide to PT practice is the information regarding professional values and guiding documents. And the main guiding document that you are all very well aware of is the APTA core values. And the PTs demonstrate, so physical therapists demonstrate professional values in their interactions with patients, clients, and colleagues. And physical therapist practice is predicated on certain behaviors that are expected of all physical therapists that are integral to all practice settings. So it's based on these core values that we'll talk about again a little bit more going forward in PI2. But these core values are what's expected of PTs to work collaboratively with patients, to honor a patient and an individual's needs and perform within professional duty and social responsibility. So the fourth area, or the fourth construct that forms the Guide to PT Practice is quality assessment. And not a whole lot that we've talked about so far, but kind of think about quality assessment as that continuous and systematic process to include the assessment of the structure of services provided, to assess the processes of care, so the adherence, and well-documented practice policies and clinical decision rules, and then assessing measurement of outcomes of care through data collection analysis. So within all of areas of practice, we should be constantly assessing or reflecting in a very continuous and systematic method to be sure that we're doing the right things, that what we're doing is working and it's benefiting our patients, and we're meeting our goals and meeting our obligations to our patients and to our peers and to society. Some additional guiding documents that I would like you to take a look at, and some of them were already posted in PI1 that we referred to last semester, but additional guiding documents that found our practice are the Code of Ethics for PTs, the Standards of Practice for physical therapists, and knowing that within each, there are general standards of practice through the APTA, but then there are also standards of practice that come through each individual state boards of physical therapy. So there are some overarching standards of practice, but then each state board will very specifically describe the standards of practice that are allowed within the state over which they are in charge of. Other documents that are available that I hope you look at are APTA has some really nice guidelines to PT documentation. They have some real nice resources that you can use for documentation, and some templates that are available if you would like. But again, just another resource for best practices with documentation and legal and professional requirements that are required of documentation. APTA also has some minimum required skills for PT graduates at entry level. And again, all of this was posted in PI1, and I can put it again in PI2. But just to be aware that these are documents that I hope you're aware of, that you should be aware of and know where they are and how to find the information if you would need. So physical therapist decision making is kind of the last piece of the, or almost the last piece of the introduction of the guide to PT practice. And you can see there that at any one time, a patient's management and decision making of working with a patient can involve other disciplines and other professionals. So at any one time when you're working with a patient, you may decide that you should not be the one to treat that person, so you may refer them out. You may consult another professional for their input to help guide your diagnosis and intervention planning. You may co-manage the patient along with another health professional, or you may retain and work with that person individually within a solely physical therapy plan of care. And if you do that, right, you decide that the patient that you're working with needs the services of a physical therapist. Within that setting, you may work with them individually, or you may direct and supervise others, so the physical therapist assistant and the physical therapy aide and technician that may also be involved in that person's plan of care. So only a couple of more models. You can see the APTA really likes to use models. And this one I know you've seen before. It's the elements of the patient-client management model. So with anytime you're working with a patient, this is kind of an ongoing iterative model and process that focuses on the needs of the patient, where you will be performing an examination and collecting data, evaluating the data, using that information to create or to come up with a diagnosis and a prognosis for your patient. Create, develop, and deliver interventions related to the diagnosis and the prognosis, and then always be collecting outcomes and outcome measures in order to determine that, again, what you're doing is working and that the patient is getting better. And this is another way to look at that patient-client management model. Again, talking about the examination and then doing the evaluation. With the evaluation, you can refer or consult. You then will diagnose and develop a prognosis, create interventions, carry out interventions, and then collect outcomes. And all of those feed back into the model. Every time you collect outcomes, it goes back into your thought process of evaluation, right? Is this working? Is this not working? Do I need to change my diagnosis? Do I need to change my prognosis? Or do I need to change my interventions? Because if my outcomes are not what I expect or what we're planning, then the treatment and the process needs to be modified for the best treatment of the patient. Okay, last one. So this last model are just some types of data that may be generated from a patient or client history, and kind of think about, you talk to a patient, you gain a whole lot of information that will help you assess and define the patient's pathology, the patient's impairments, the patient's functional limitations, and their participation. So within this model, you're going to ask a person and get information regarding their activities, their current condition, their family history, their general health status. And you can read through here, but it's just a way to think about all of the information in kind of little chunks that you will gain from a patient or a client history. And this really sets the stage for your further examination and your further evaluation and your diagnosis, your prognosis, and how you're going to measure those outcomes. So again, just one final model to kind of help describe and depict some of the information you're going to get from patients. So that's it. And I would like you to please look back through the guide to PT practice to kind of review some of these and just to see what's there, where to find it, how to access it, and all of the other information that's available to you based on the APTA website that will help you in terms of professional practice. Thanks, everyone.